All right, welcome to the Explainer. Today we're putting a really interesting and often underestimated bug, Proteus vulgaris, right under the microscope. We're going to cover everything from how to spot it in the lab to how we can best fight it at the patient's bedside.
And just a quick heads up, all the information we're covering today was pulled together using a comprehensive deep search. If you want to dig into the primary sources, the full notebook is available for you to check out.
So, here's our game plan. We're going to follow a classic lab bench to bedside structure. We'll start with a general overview and how we identify it, then we'll get into its clinical impact, how we treat it, and finally, how to prevent it.
Okay, let's dive right in. To really get a handle on any pathogen, you first have to understand where it fits in the big picture, what makes it tick, and who are its close relatives.
Proteus mirabilis usually gets all the attention, right? It causes the vast majority of Proteus UTIs. But Proteus vulgaris, while less common, is distinguished by a couple of really key biochemical markers. The big one, it's indole-positive. That simple spot test is still the bedrock for telling these two apart in the lab.
Now let's look at its family tree. Proteus vulgaris is part of the Morganillaceae family. And this isn't just trivia for us microbiologists, it's super important clinically. Why? Well, because members of this family, they share key traits, like being intrinsically resistant to certain antibiotics like the polymyxins. Knowing its family tells you a lot about its behavior before you even run a susceptibility test.
All right, let's head over to the lab bench and see what this organism actually looks like during a real workup.
The swarming motility. It's beautiful, but man, can it be a headache, right? It just takes over the plate. But when you get it on selective media, like McConkey, you see those classic non-lactose fermenting colonies, those pale colonies that help us isolate it. And yeah, then there's the smell. If you know, you know.
And this table just lays it out perfectly. The key takeaway? Proteus vulgaris is indole-positive and ornithine-negative. That's the complete opposite of Proteus mirabilis. These two simple, classic biochemical tests are still an incredibly reliable way to differentiate these two important species.
Okay, so we've got it identified. Now for the interesting part. How does Proteus vulgaris actually make someone sick? What's its playbook? Its #1 weapon, its most formidable tool, is a powerful enzyme called urease. You can think of this single enzyme as the engine driving pretty much everything that goes wrong in a urinary tract infection caused by this bug.
So here's what happens. The bacteria pump out urease. That urease finds urea in the urine and splits it into ammonia. All that ammonia jacks up the pH, making the urine incredibly alkaline. In that alkaline soup, minerals like magnesium and phosphate start crashing out of solution, and bam! You get these infectious struvite stones. And these aren't just kidney stones, they're bacterial bunkers, creating a protected niche where the bacteria can hide from antibiotics.
And clinically, what does this look like? Well, mostly complicated UTIs, especially those nasty catheter-associated infections we see in hospitals and long-term care. But its reach isn't just limited to the urinary tract. It can cause some serious wound infections, and if it gets into the bloodstream, can lead to life-threatening bacteremia and sepsis.
Okay, so now let's shift gears to the bedside. How do we actually fight these tough infections? First things first, we have to talk about its resistance profile.
This is so crucial. Proteus vulgaris comes with a built-in resistance profile. It just naturally shrugs off several common antibiotics, like nitrofurantoin, which is a go-to for simple UTIs. It also has a chromosomal beta-lactamase, an enzyme just waiting to chew up many of our penicillins and early-generation cephalosporins. This is exactly why you can't just guess, you have to test. Now, when you get that susceptibility report back, you might see the EUCAST category I, and it is so important to understand what this really means. It's not intermediate. It's an actionable signal to the clinician. It's saying, hey, you can win this fight, but you might need to increase the dose or use an extended infusion to make sure enough drug gets to the site of infection.
And this table shows you the numbers behind that decision. These are the EUCAST breakpoints for some of the big guns we use. Any MIC that falls in that gap between the S and R values, that's your I category. That's your window of opportunity to treat effectively by optimizing the dose.
It's really interesting when you compare treatment guidelines. You've got the Dutch SWAB guidelines, which are pretty direct based on their local data. Use this, don't use that. Then you have international guidelines from the IDSA, which offer more of a flexible, risk-based playbook. They also really push for shorter treatment courses when patients are responding well, which, as we all know, is a huge part of good antibiotic stewardship.
Now, for kids, things are a bit different. Two big takeaways here. First, getting a clean sample is non-negotiable.
For febrile infants, that means a catheter or suprapubic aspirate. Second, you're generally reaching for third-generation cephalosporins right out of the gate because of the high rates of resistance to older agents like ampicillin.
Okay, for our final section, let's zoom out and talk about prevention. And really, when it comes to Proteus vulgaris, this conversation is almost entirely about one thing: urinary catheters.
And this table really sums up the best strategy we have. It's not one single magic bullet. It's a whole bundle of care that covers the entire life of that catheter. It starts with asking, is this even necessary? Then it's about aseptic insertion, proper maintenance of the closed system, and, this is the big one, getting it out as soon as it's no longer needed. This is where we can make the biggest impact.
So, all of this leaves us with a really critical question for the future, especially as we see more and more antimicrobial resistance. How can we, the folks in the lab, and the clinicians at the bedside work together even better to stay ahead of challenging pathogens like Proteus vulgaris?
We really hope you found this deep dive into Proteus vulgaris useful. If you did, do us a favor and subscribe for more explainers like this one. And seriously, we want to hear from you. What did you find most interesting? What other pathogens should we tackle? Let us know in the comments below. We actually read every single one. Thanks so much for joining us.